Good afternoon and welcome to our October Dementia Dialogue. My name is Heather Mulder and I'll be your moderator today. Our topic today, we have been this entire 2016 taking a really in-depth look at Alzheimer's disease, and October brings us to advanced dementia. Before we get started, I want to go through a little bit of housekeeping. Of note, our session is being recorded today, and it will be posted on our website shortly after the broadcast ends this afternoon. We do have the ability to accept questions throughout the program today. You can look at your control panel on the side of your screen and enter any questions. We will collect those questions and address them at the end of the session. Please note that if we don't have time to address your question, we will take time after the dialogue to respond to any concerns that you have. Additionally, you will notice in your control panel there is a handout pane. If you would like a copy of today's presentation, you can obtain it through there. It is my pleasure this afternoon to introduce you to our presenter today, Jan Dougherty, who is the Director of Family and Community Services at Banner Alzheimer's Institute. This month actually brings us to an exciting time at Banner Alzheimer's Institute where we are celebrating our 10-year anniversary, and Jan has been there since day one, shaping, creating, and developing all of the programs and services that are provided through Family and Community Services. Of note, in the past few years, Jan has become a fellow in the American Academy of Nursing and also received a Piper Fellowship. I'm going to go ahead and turn our call over to Jan Dougherty to discuss understanding advanced dementia. Go ahead, Jan.
Thank you, Heather. Well, it's my privilege to be here today and kind of walk our listeners through this final stage of advanced Alzheimer's disease or related dementia. So over this next hour, we're going to be diving a bit deeper into helping participants understand many of the changes that take place in both memory, thinking, mood, behavior, language, and function over this final 1 to 3 years of dementia. We're going to use this information, though, to better understand how caregivers can craft strategies that not only help them provide care, but hopefully to maximize connections with their loved one during wakeful hours. And then finally, because this is the advanced portion of the illness and death is what follows, it's really important that we take a look at healthcare decisions to understand what are likely the things that might happen that families are going to need to address. So with that, let's just begin to explore a bit what now is happening in this advanced stage of Alzheimer's disease or related dementia. And quite honestly, no matter what the form of dementia is, in the final stages or this advanced stage, sometimes it's referred to as late-stage Alzheimer's disease. Some people will call it severe dementia. Regardless, we're going to see consistent change in memory, thinking, language, function, and behavior. As we look at changes in memory, we've known for many years, particularly in Alzheimer's disease, that short-term memory has been non-existent. But now we're also going to see that long-term memory changes in a very significant way, in different ways that we might not have appreciated. One of the probably the most families often dread is that this person no longer recognizes who they are. They can't call them by name, and they certainly don't understand the relationship. And while this is particularly hard for especially spouses and adult children to witness this sort of change, I guess having spent a significant part of my career in the advanced stage of the illness and working with people during that time is that people with advanced dementia very much do know that they're in the presence of someone who loves them. So I want to encourage listeners not to be disheartened, and certainly it is difficult when facial recognition, name recognition is no longer there. We always know by the nonverbal who cares about us. Along with changes, though, in memory, is there are these changes in verbal skills. And so even for people who have intact language abilities, and there's going to be more variability than in and other areas within the brain function, people just can't seem to tell these well-rehearsed stories in the same way because their memories of what has happened really has fallen apart. And sometimes people will just kind of start filling in the gaps, which could be based on nonsense, and we often call this confabulation. But it's frustrating for those things that were once so overlearned, if you will, to now be forgotten. At the same time, individuals will even have difficulty following more than a one-step command. So we might tell the person to sit down or take a bite, but if we try to combine more than 2 steps together, we're going to find that the person is unable to follow through. As we look at a very significant way as well, in that it's very challenging to carry out a conversation because of the ability for the individual to put words together, but also being able to understand what's being said to that individual. In fact, words and sentences might become very disconnected for some, and maybe new words are made up that we don't understand, or perhaps the words just become jumbled, and it's often called word salad. For those who spoke another language other than English, usually, but now in the advanced stage, again, you might see as part of the word salad both a language other than English being jumbled along with, we really want to participate in that communication. We want to understand what the person's saying, and we try so hard, and yet often, again, words can become very confusing, and it's very difficult because most of us use our words to communicate, and keeping it simple is much better because of the ability to understand and interpret what's being said. However, one thing that stays intact throughout the whole entire course is verbal communication. So it's really important that we think about that and appreciate using it in many ways. What we do want to note is that the facial expression, the tone of the voice really convey a continuum of both comfort to discomfort. Clearly, our voice tone and our facial expressions is that of the person with advanced dementia. So we're always looking at that nonverbal communication from their end as well, trying to receive and understand, or is this now on the more uncomfortable discomfort portion of the continuum. We know that behavioral expressions become the primary and further explore that. Again, as part of that behavioral expression, we really change. You know, it's just so much harder for a person with advanced dementia because of the pervasive changes that have occurred in the brain for whatever the pathology is, whether it be a frontal temporal dementia. There's this degeneration happening in the brain that just makes it so much harder for a person to be present. They often appear to us as being either withdrawn or disinterested, when in fact there's just so much discomfort what's going on around them. When they are awake, it takes so much to be present that, as you can imagine, it causes kind of overwhelming fatigue. So some 16 to 20 hours during the 24-hour period. I do want to point out, though, that depression and anxiety is why, you know, this idea of behavioral expressions becomes incredibly important, especially for family members who really know their loved one, to really be looking in the eyes and really noting kind of these nonverbal cues that we're getting can often indicate that a person just kind of psychologically is uncomfortable. And these would be important for, obviously, us to note and providing this information to whoever our medical provider is. And this idea of behavioral expressions not only is communication, but it becomes the primary mode of communication when there's an unmet need. So I kind of want our participants to think about infants. And when we're talking about developmental changes consistent with Alzheimer's, talking about the changes in the brain that really bring an adult, a full adult, into more of a responsiveness, meaning that if you lack language skills, your behavior is really going to help guide at what might be an unmet need. we see because of these ongoing changes in the brain. And one of the things that we're more likely to see is as the person moves from the moderate to the advanced stages is this nation in movement, making walking much more difficult. Because we all want to move and it's somewhat unconscious falls because they don't realize that they need assistance. They don't appreciate that this loss of balance is taking in all aspects of daily care, from dressing and grooming and bathing and even eating. And when the person bites using fingers and finger foods, some might be able to take a few bites with a spoon, which becomes more the universal utensil at that point. We find that distracted or fatigued, and so it's likely that we're going to be feeding a good portion of the meal. Likewise, drinking out of a cup can, especially when we're the ones providing fluids to the person. So many will really prefer to drink from a straw rather than directly from a cup. So we've reviewed these changes to really talk about what are strategies that caregivers might utilize to in care and connection. So as we think through strategies to aid in memory and thinking, it's always important for us to kind of, again, reset our expectations and appreciate that doing the very best that they can. So if we go in, let's say they're living in a residential care facility, and we go to visit and they tend to be sleeping, we might think the person had already been up for 2-3 hours and that doing their best right now is what they're doing, which is sleeping. So we really have, we need to understand that it's so imperative that we engage this individual during their best time of the day. So whether they're in another residential setting, knowing what that best time of the day is going to be incredibly important. I've worked in residential settings where, in fact, for some individuals, the best time of the day is going to be at 2 o'clock in the morning, and that, too, is incredibly important. Thinking about how is it then we practice during those wakeful hours rather than thinking that it's now 9 a.m. and they should be up and this should be their best time of the day. So that's a really important element. If we are approaching them as they're just waking up, it's really important that we just give them time, first of all, to wake up and be present with us. You know, we've already stated that brain connection of looking at you and knowing who you are. So rather than quizzing them and saying, do you know who I am? It's much more beneficial and letting them who we are, whether it's, hi, Mary, it's your husband, John, or hi, Mom, it's Jan, and I'm so glad to see you today, and I'm going to be taking care of you. So whoever you are relative to that person, it's just a respectful thing to do to allow just a very gentle introduction and reminder of who you are. And obviously, as in the past, we're not going to correct them, or we're certainly not going to quiz them. This is a photo album and say, who is this, who is that? Or perhaps they do have better language skills and they are trying to tell a well-rehearsed story that's completely incorrect, and to go with the flow. Speaking of that, because we really depend on that, it's again the foundation of our relationship is built upon communication. In our field, we often talk about using a soft approach. That means we're gentle, we're slow, we're very purposeful, because remember, this person's brain is processing all this input, whether it be verbal or nonverbal. We just want to be very intentional with our actions. We're softening our voice, we're smiling, and we're speaking in much shorter and more simplified sentences. As we've already said, is that the nonverbal is nonverbal. So it's so important not only as we approach them, introducing ourselves to them, but this helps to appeal to the emotion and allows them to feel safe. You know, I often imagine, having cared for people with advanced dementia, how frightening to have someone come at you very quickly to perhaps give oral care. So you don't know who this person is and they're coming at you with what appears to be a lethal way. Introduce yourself to me. If you didn't move in a very slow way, I'm likely to feel very unsafe, and my behavioral expression might be striking out at you. And now you're telling me that I'm physical, and in fact I felt unsafe. So this idea of just slowing down and using this soft approach and allowing that person to feel that they're in the presence of someone by much greater success in every aspect of care. Because, again, we're such a language-based society, we know that family discussion with their loved one, again, nothing feels worse than sitting in silence with someone. So we're going to ask you to lead the discussion, but so did you like that? Isn't that a beautiful picture? Isn't she cute? Something like that would be the simplified sort of, and that is sitting still for a matter of seconds, allowing for that person to respond. And in response, it's amazing what we can receive back from this person. Again, I love prompters as a way in discussion, because if words fit 1,000 words, it might prompt what we're talking about. And so pictures of people, and it could be family members, again, not saying who is this, oh, what a lovely dress this is. I think she looks good in red. What do you think? And using photo books, particular photo books that show images, hobbies, or people, whatever that might be. Animals really can prompt some wonderful time together and discussion, as can both music and food. You know, don't be afraid to laugh out loud. People too, that's again nonverbal, can laugh along. And it's often not uncommon when to see the person with advanced dementia to join right in. As we think about just know that your input and what you know to be different about mood and behavior, person often 8-10 years, and you understand kind of what their affect looks like, what this nonverbal means to you. And so we're definitely watching not only for facial expressions like grimacing, but we're also looking at repetitive movements, people who start tapping or picking or any kind of vocalization, repetitive vocalization, particularly if it has a negative quality to it, probably is signifying. And that will be essential for you to be able to communicate to your healthcare provider, because it could indicate perhaps that the person is in pain, or perhaps the person is constipated. It could mean a variety of things. So your input would be incredibly important to be providing to whoever your healthcare provider is. We talked a little earlier about that behaviors become a primary source of communication during advanced dementia, and these usually represent unmet needs. So I want to explore that, what that might mean. So as we say, well, what's an unmet need? I think often of the Maslow's hierarchy of needs, where we began at the very lowest level of shelter. And so I think about just emotional needs of individuals with advanced dementia. Again, mind, body, spirit, and their spirits, their souls are alive and still are sensing. And so does the person feel safe? Do they feel loved? Are they free of anxiety and depression that we know can still co-occur in advanced dementia? And if they are, how are we going to treat them? Or perhaps are they feeling overwhelmed just because the environment perhaps is too noisy, or we're pressing them to do something perhaps they don't want to do? We often see bathing as being an overwhelming activity in people with advanced dementia. So if they're in a shower room that's cold, that's got echoes, and you're sitting buck naked on a shower chair, you can see where one might feel overwhelmed, where perhaps if they had a bath blanket covering them, if the shower had low lighting, if the room was warm, if there was some music playing, again, what that's going to create a sense of is, again, safety and love. And so those are the kinds of things we want to think from an emotional perspective. Often, though, there are many physical unmet needs for people with advanced dementia that also could come in negative vocalization or repetitive motion of sorts or even facial grimacing. They could be hungry. It could be that they were presented a meal at a time that they were just too fatigued to eat, or they didn't have much of an appetite, but now 30 minutes, an hour later, they do. Could they be thirsty? Could it be that they need to use the toilet to urinate or to have a bowel movement, or perhaps they are in a soiled brief and that feels incredibly uncomfortable? I think about temperature as being significant. Remember that many or most people with dementia will be older people, and just how their body responds to especially cold is very different. They lack the subcutaneous fat that was once there. Their ability to have that shiver factor to help them warm up is no longer very effective. And so if the rooms are excessively cold, that's going to be very, very uncomfortable. Then if things are too noisy, or perhaps there's some sort of background noise that is somehow noxious to them, we really want to think that through. Again, if a person is so overwhelmingly fatigued, that too is an unmet need that's going to come out as a behavioral expression. Perhaps they want to move and they're in a chair and they're not being allowed to move. Maybe they even have a safety seatbelt on that keeps them there, and it's not meeting their need for movement. And then finally, we think about the physical discomfort of pain. By the way, developing advanced dementia does not cause pain, but rather it's often the lack of movement that leads to discomfort. I often call it the aches and pains that are associated with lack of movement along with older age. So that when a person has been sitting in a spot for a prolonged period of time because they can't reposition self, it will be uncomfortable. Might be achy, pain might not be the exact word as we describe it, but certainly there will be discomfort, and that would represent an unmet need. Again, I come back to the spiritual unmet needs for some, if not all, and that's this desire for people to feel connected to the universe, the world that they live in, and for those who have had a religious past, to feel connected to the divine is an incredibly important thing that we also pay attention to. So as we think about meeting unmet needs, typically, always looking at the person and determining, do they first feel comfortable in our presence? And then it's almost kind of walking through one by one. Have they eaten? Have they had something to drink? Are they positioned comfortably? Are they wet, or do they need to use the toilet? Is the environment comfortable? Meaning, is it warm enough? Is the noise minimized? Is it time for a nap or bedtime? Is there untreated pain that needs to be attended to? Those are the kinds of ways we're going to walk through to better understand unmet need. So I've just kind of outlined the strategies to aid in meeting these unmet needs. Routines are incredibly comfortable. We talk about that right at the very early stages of Alzheimer's disease or mild dementia, where we say, our routines provide tremendous comfort because it provides certainty. And so it goes with people with advanced dementia. We still want to maintain those routines just because of the comfort that they provide. Again, we're always looking for these behavioral expressions to identify that there's an unmet need. But then we do one better, because we learn to anticipate when needs are more likely to arise. So if we know that for in fact, the evening, which can cause a much greater confusion and sundowning, if we know that that's likely to happen, then as we anticipate that, perhaps we find that a late afternoon or even early nap, rest period, really with some music and a bowl of ice cream might help ease that portion of the day. Perhaps the behavioral expression will be minimized. So learning to understand behavioral expressions look like more when they're likely to occur will help us, again, think through ahead of time so we don't see that sort of expression happen on a frequent basis. Again, we learn to watch for signs of pain, and that's really important. because that's something that we can treat very, very effectively, often with just routine use. It would be something that you would observe as after all the needs have been met, and if this behavioral expression continues, that would be one of the things we might ask the team assess it even further. But I also think about using other forms of distraction when we're meeting the needs of individuals, like massage. Let's say we do have someone that has some pain due to osteoarthritis, and we know that moving them can be, so perhaps providing a light massage before or after in that area. Perhaps it's the hips that might hurt. Just doing light touch in that area or palm could also be soothing. So there are a number of things that can be utilized to keep someone uncomfortable. I remember once bathing a woman who found me uncomfortable. So not only did we keep her fully wrapped with a warm blanket and kind of lifting the blanket only to wash under it, but giving her Hershey's Kisses to really kept her comfortable. And I would say those would be strategies to meet an unmet need. Again, movement, working with people with advanced dementia, movement is freedom, comfort. And so knowing that people are going to keep this person moving for as long as possible, because here's what I've learned. None of us are looking forward to living our days out in a wheelchair. And when people are put in wheelchairs prematurely, what we see is not only do they lose the function in total, and these are folks who are often trying to get up unassisted, who are calling out. They don't want to be there. So we need to, again, anticipate the person's desire. So if for the person who's up in the morning, perhaps we want to schedule the movement even before breakfast. So perhaps we're working on simply sit-to-stand movements. Really important, we want to maintain strength within the quadriceps person and taking their hands and having them move from a higher seated position to full upright position, back down again, up and down. Not only is great exercise, hopefully they'll be more comfortable later that morning. Or for the person who's even able to take a few steps, how therapeutic that can be just to walk even short. Again, people are going to be sitting more at this point because they're walking less. So it becomes incredibly important that we think about providing comfortable seating and position. Not only is it difficult to coordinate movement of feet, so imagine trying to shift your bottom sitting in a chair or trying to turn over in the bed. We're going to find that people really need our help to try to assist them to reposition every couple of hours. And that's especially important because we worry about skin breakdown, particularly over these bony areas of our body, the back and the buttocks, and people who have less body fat are going to even be more prone to skin breakdown. So we really want to watch for that. So incredibly important. Now, what we do know is that, this is when back injury can take place. So for family members, we want you to think about your backs as well. So we want adaptive equipment not only to keep your person safe, but boy, we want to keep you safe as well. So this is the only picture I think I put in the PowerPoint, and that is to show the importance of a gait belt. So here you see a gentleman and this white belt that is secured right around his waist, above his hips. Again, it's very snug, and you'll see this is really a must for caregivers, whether you're a professional caregiver or you're a family caregiver. These gait belts really assist if you're standing, if you're wanting them even to take a short walk with you. The gait belt will help you hang on to that person and keep distances. A front-wheeled walker would be helpful. Again, the only difference, remember, I think most of us have seen these. These are the walkers that have small wheels on the front, often to secure the walker, but it will provide not only stability but ease for the person to take a few steps further. Because sitting is going to be much more common throughout the day, we want to think about chairs that can be helpful. So certainly recliner chairs, and many people think about lazy boys. That sort of chair can be helpful because we do want to keep the legs in an upright position. Otherwise, swelling will occur in the ankles and the feet, and that won't be comfortable. Lift chairs provide another opportunity, particularly to assist that person to come to a standing position before they get up and move. So again, incredibly helpful for family members who are trying to assist their person to stand and maybe even do kind of a bathrooms need a lot of adaptation if people are to continue using them. Shower chairs, hopefully this would be a shower chair, would be incredibly helpful to provide secured seating while a bath is given. Likewise, a raised toilet, incredibly helpful, along with maybe even a bedside commode in the bedroom at night so the person doesn't have to walk very far. The caregiver can do simply to a commode, again with the goal of keeping this person dry. For the person who's spending more time in bed, we just want to make sure that the bed is comfortable. So there's all kinds of now that are available, and sometimes talking to your healthcare provider about whether you're better off with foam, air, water, or gel. Many opinions on that. Some people might benefit from a hospital bed at home. It can be an incredibly helpful device for the family to be able to move the bed up and down, getting it in a comfortable level, back injury. Now, I'm a huge proponent of home health care. This would be a Medicare or insurance covered benefit that would provide a skilled area of movement. Physical therapists provide just an outstanding service to family caregivers as they can provide education and assistance, how to lift someone carefully, how to help move them, transfer them from one surface to another, and even positioning. Home health care might send out a nurse, though, evaluation and safety, and maybe even a certified nursing assistant who could assist with bathing. Now, all of these adaptive equipment sort of by insurance. So it's really important to work with your medical provider for the appropriate orders, whether it be for home care or for some sort of adaptive orders or prescriptions are given, so that any insurance authorization that's needed can be carried out, so you would know whether it's covered or what your share of costs might be. Let's talk about now strategies to adapt. It continues to be probably the most enjoyable part of advanced dementia. But there's obviously a change, and you've seen this change in preference long before now towards soft and sweet. So it's all about texture and taste at this point. And we know particularly food that is sweet and in soft in texture is more readily accepted than those that are not. Again, we're going to begin to see changes, and typically see this as the person is losing the ability to walk. We'll find consistent issues more with chewing and swallowing. So when we see a person not chewing, in fact, they're holding the food in the side of the mouth, and we call that pocketing food, it's probably a cue to us that it's time to eliminate beyond what the person has the capacity to do, that chewing element, and then using the tongue to kind of thrust it to the back of the throat to be choking as the advanced stage of the illness progresses. And that's probably our biggest indicator for hospice, as people begin to choke more frequently, choke on food, but what becomes even more problematic is often choking on thin liquids, so juices and waters and the like. There are commercial thickening agents that you can add to the drink, and it will thicken it, so it makes it more likely for the person to be able to swallow, and less likely yogurt, a milkshake. That's the kind of consistency that we're looking for. And in general, we see less choking with that sort of consistency. Focus, and again, remember, processing is slower, and so is kind of the partaking of food and fluids, that it can even take up to 90 minutes that we're watching for fatigue. Therefore, thinking about 90 minutes, not whether you're a paid caregiver to be providing a meal, people are just going to poop out, and they're not going to be able to complete their meals. So this is where we want to think about providing their awake hours. So if we've only got 2 times a day that we know that they're going to be awake, we're going to plan the meals during that eve. So if the amounts are going to be smaller, we really want to think about calorie-dense foods that we're going to use. Feeding many people with advanced dementia, that if if they see a plate that is just loaded with food, that can be overwhelming and really take away the desire to eat. So presenting perhaps one thing at a time or on a much smaller plate seems to be much more palatable and much more doable. We want to eliminate distractions from the room, anything that could take them away from the sole focus, which is the enjoyment of food, we want to think about. So I think we've all had those experiences in dining out where the restaurant was either so cold or so loud that it really took away from the pleasure of the food. So apply that thinking about the person you're trying to feed now with advanced. Off the TV, maybe music that's pleasant could be really helpful, and making sure the room temperature is warm is going to help them tremendously. Obviously, we want them seated. We really want to maximize their ability to swallow and not be choking. And we found that actually having pleasant conversation, think about, isn't that mealtime for most of us somebody that we care about? Again, not talking in an excessive amount, but just having some small chatter. There's also been studies showing that staff in care facilities who eating, that individuals will eat up to 30% more. We talked a little bit earlier about using straws, but then also at the same time thinking about getting smaller amounts. So where we might normally present a glass of fluid in an 8-ounce glass, if we think about using a juice-sized glass and perhaps every couple hours, we're likely to see greater fluid intake at that point. Care. As we know, what happens relative to loss of bladder and bowel control, the mechanics as it does to really the memory to recognize the stimuli, meaning full bladder or bowel that would need to be evacuated, and then trying to figure out where do I go, toilet. So we do see incontinence come as part of advanced dementia. I would say it's brief. And it's important to really look at buying a brief that's going to support your person's needs. Sometimes we shop by price, and this is one of these times I'm going to say really shop around and find the product that's going to suit your loved one. It's possible for you to get your person up or to be checking their brief every few hours, then you're going to want to have a very absorbent sort of brief that pulls this fluid away from the person's body. If the person does have ability to move from sit to stand and to do a pivot to a toilet, if it's feasible, getting them to the toilet every couple of hours will minimize wet episodes, and let's face it, it just feels better to urinate into a toilet than it would into a brief. On a toilet, we want to think about obviously a raised toilet seat because that eases the movement from up and down if you're the caregiver who has to help them get up and down. But I would also say topper, and this would be kind of the potty training seats that we use for toddlers. Again, they're padded, they fit nicely onto the toilet, and what we're trying to do is ease or very thin. Because nothing feels worse than these bones kind of grinding into a hard toilet seat, which most of us size, how much more comfortable it is to have a bowel movement sitting on a toilet than it is laying in a bed or sitting in a chair and having a bowel brief. I will tell you, in terms of unmet need, that sits high on my list as something I want to share with my caregivers, is please allow me to have a BM on the toilet where we look at habit training and what kinds of foods can stimulate a bowel movement. For most people, it's in the morning following breakfast and a cup of coffee. So if seek out a healthcare provider, often a nurse is your best source of reference to help with that. But again, tremendously comfortable to toilet. Finally, let me just comment about underpads, which thank God we live in a time where we have these inventions of both disposable and washable underpads for caring for their loved one at home. Having to do sheets every single day on top of everything else, it just becomes overwhelming. And so we're using these underpads for the beds and the chairs, but to perhaps even provide that added comfort where we don't have to wake that person during the middle of the night to change a brief. So again, really do your homework on finding a product that works best for you and your person. I'm not going to say a lot about preview that our November Dementia Dialogue and our Beacon is solely focused on meaningful connections during advanced. It should be provided during the wakeful hours. And I know that should be kind of a no-brainer, but sometimes we're wanting to do things to people when they're kind of half awake, half asleep. So that means eating, bathing, grooming, dressing, all of those what we call activities of daily life. You engage them, and it's going to be based on lifelong preferences, and we're going to talk in great detail in November about that, so I hope you'll tune in. To a residential setting outside of home. So knowing who this person is the idea of creating a life story, I think, is essential. You know, it just is a short biography that just allows these paid caregivers to know, or what are they all about, and how is it that I provide them better comfort. So here we have on your screen that just says, you know, what you prefer to hear about, what are you most proud about, what's music that brings meaning to you, how you like to be touched or not touched, what families should share with care staff. And then I would recommend that these life stories be person's bedside is. Often that's where care is being delivered, and it really does help for paid staff and volunteers to learn a bit more about your loved one. Let's talk just a little bit about an advanced dementia. Death for people over age 65 in the U.S. here in Arizona, cause of death. And again, it's not that we have stuff in our groundwater, rather it represents the number of people, particularly over 85, who are being diagnosed with Alzheimer's disease or related dementia. So we know that the cause of death in dementia is typically due to aspiration pneumonia or some other type of infection. And because we already know this, what are those potential end-of-life situations that might arise? And make sure that not only we're revisiting healthcare directives, maybe we have with our loved one at an earlier time that might guide us into the decisions we're going to be asked to make. Have wanted CPR? Would there be a desire for a feeding tube? And I'm not going to go into each in specific, but these are kind of the types of things that might be asked. So if you end up in a hospital, and the person isn't eating, would they want a feeding tube? Drinking enough fluid? And would they even want to be in a hospital, knowing that hospitals are there to treat acute illnesses? And yes, and the cause of death, would we want to be in an uncomfortable surrounding like a hospital? And finally, would we want to use antibiotics to treat infections, particularly if we know that they're not particularly effective in treating infections? Ideally, these choices should have been reviewed when the person had capacity and were able to state their wishes, but sometimes it's something we're uncomfortable doing, or we just don't think about it after the diagnosis has been made. So we often ask family members then to make these decisions. Usually, if there's been an appointed medical power of attorney or healthcare power of attorney, it's going to be that individual who will execute the healthcare decisions that are likely to go. Medical power of attorney here in Arizona, we have what we call a surrogate decision maker, and they're appointed based on their role to the person with advanced dementia. And they usually go in this order. For spouse, it would be a majority of adult children. If no adult children, it could be a parent followed by a domestic partner, a sibling, a close friend, or finally an attendant, asking them to substitute their judgment based on what they believe the person with advanced dementia would have wanted. And finally, if none of those are available, or the majority of children where they're fighting over what the parent would or would not have wanted, this might lead to a guardian being appointed, and this is a court-appointed role in which a guardian makes medical decisions on behalf of the person with dementia. So a guiding principle to consider if decisions haven't been made up that was never talked about, we found this very helpful in discussions with families, and that is to ask yourself, if the person could see their situation for what it is now, what is it that he or she would tell you? And that can be just really helpful to kind of stand back and say, yeah, if this were them looking at their situation, what is it they'd be whispering in my? I tell you, we've got a whole class about planning ahead that includes this issue on healthcare directives and medical power of attorney, and the information is onto our website, and listen to this very valuable class called Planning Ahead. So one other thing to consider is medications, and we know that medications for a long time, and particularly if swallowing issues, should be reviewed each year, but particularly when there's a change in condition, and that even includes medications to treat Alzheimer's disease. So there might come a time that we think that there's little benefit in using those medications. We would encourage patients be slowly titrated or slowly stopped to determine effectiveness, and really being careful to watch more for function, mood, or behavior. Probably was keeping that person comfortable. I recently met a wife whose physician decided, with her husband being in the advanced stage of the illness, he developed a severe delusion thinking that he was on an island drowning. So clearly that Aricept was providing benefit. That might be an example or not. Finally, the question comes, when is it time with an end-of-life diagnosis? And it brings that team of professionals to wherever the person lives. People become hospice eligible for dementia when they're in the advanced stage of the illness. So again, they need total assistance for all aspects of daily life, including continence care. They lose meaningful conversation, and hospice often is looking for less than 6 words. And on top of that, in the past month, they've either had an aspiration pneumonia, maybe they have multiple pressure, or what we call bed sores. Maybe they have had a fever that comes back following the use of antibiotics, and usually they've lost helpful. So how do you get hospice care? Well, you should be talking to your primary care doctor or your dementia specialist about an evaluation provided to you as well. Well, in summary, as you've learned, dementia really takes its toll. That you've been able to glean some new strategies to help you provide the kind of comfortable connections that you're looking to seek ahead for this advanced stage, to provide the comfort that I know you're seeking for your loved one during the end of life. So with that, I know I've just got a couple minutes.
Great. Thank you so much, Jan, for this quite in-depth look at advanced dementia. I know you shared a lot of really beneficial strategies. Unfortunately, we're not going to have time to address many of them today, but please know we will respond to them after the close of the dialogue. Maybe one that we could just touch on very briefly before the end of our session. We had one of our attendees asking and talking about their person standing when they're no longer able to stand or balance on their own and they're having a lot of falls. Would you recommend the use of that seat belt or the lift chair that is reclined to try to prevent that, or do you have some quick strategies you could share to help in that situation?
That's a situation that arises. Again, it just speaks to how comfortable we are to want to move. So this is where I'm going to want to anticipate some things. One is the fact that they still want therapists to see if that's even feasible, and how we might plan maybe even twice a day for, especially if it's to be present with a gait belt, to help that person stand for a very short period of time, and then seating them more comfortably. This is where I would look at it, though, a really good recliner chair that could be more comfortable. What I've learned with seat belts is, boy, people don't like them. They often fight them, and they can still get out of them, and the fall will be much worse. I'd be positioning and probably something to keep them occupied during those wakeful hours so they're not focused on wanting to get up.
Great, thank you. A few really good to share with our listeners today. Thank you again to Jan for discussing this important topic and sharing your wealth of expertise about advanced dementia with our listeners today. And it will be posted on our website within 48 hours of the conclusion of this dialogue. When we close as well, you will receive, and please do take a few minutes to respond to the questions. Let us know what you thought, or if there's any additional topics you would like to learn about. With that being said, I will invite you to join our discussion of advanced dementia We're talking about honoring the spirit of the person with advanced dementia. That will be on November 16th, and you can register on our website, banner ALZ. Again, to our attendees and to Jan Dougherty, have a good afternoon, and thank you for joining Dementia Dialogues, where we bring the dementia education to you.
Then usually